Hello. Welcome. This is a Thursday evening rendition of Dr. Childress. I know I'm coming on Facebook Live on Sunday morning to talk about treatment issues, but I'm exploring various aspects of the internet and the internet communication medium. And I love the internet. One of the nice qualities about it is that I can just hop on Facebook Live like this whenever I want to, which is a very interesting quality of the media. So I figure I might just jump on from time to time, just at random, just to talk about things at random. So these are sort of off the record, on the record conversations of an evening with Dr. Childress. So instead of coffee, I have my glass of wine here, and we'll just sit around and talk about things. So I'm done with my day today, settling in, got Mr. Pippin all settled in, and thought I'd just use the medium, check in, surprise you with a video here, and just talk about some of the places we are right now, some of the things that are going on with my life, with the situation in the family courts, and probably wind up on the individual therapists. That's what I kind of intend to address at some point here. But to sort of orient to where we are, where you are, where I am, is the parents here, everybody here has a thought disorder, or thought difficulties in understanding the situation. The pathology captivates people, it captivates their motivation, it triggers fears, it triggers insecurities, and seeks allies, gets allies to join up to. So it sort of controls the dynamic of people's minds over here. And everybody's sort of misoriented to the situation and what's going on. The fundamental failure is in the mental health people, the forensic people. And that's a two-part kind of issue. The clinical psychologists abandoned you, and they gave you forensic psychologists that isolated you away from knowledge and everything else. And then they gave the forensic psychologists carte blanche to do whatever they want. So over the last 40 years, the quality of practice has declined substantially. There is no quality, there is no knowledge, there is no um, competence over here. And it's been that way for 40 years. And clinical psychology has stayed away. And that's why there's no treatment over here, because there's been no clinical psychologists over here for 40 years. And so we have to get them back. And that's dialectic behavior therapy, modified for the family courts and things like that. But the pathology captivated parents who are the driving force to protect the child. And it captivated them on this false belief that they have to prove a pathology to a judge, this parental alienation thing. And so it drives them into the courts to prove a pathology to a judge that's impossible to prove because it's such a weak, awful model for a pathology, parental alienation. And there's still this fringe group out there that is still trying to offer it up as bait for parents, essentially. Parental alienation, prove it to a judge. And no, you don't need to prove anything to a judge. You need competence from your mental health people. But it's all a shell game, basically, over here. And so the parents get triggered into their fears. There's a new crop of parents showing up all the time. So by the time they figure out that parental alienation, that construct doesn't solve anything, they're already 3 or 4 years into the court and the pathology is pretty well developed. What needs to happen, this is a very standard pathology. It's a trauma pathology, narcissistic borderline, dark personality pathology, collapsing into a persecutory delusion, shared persecutory delusion with the child. It's a trauma pathology, so it's very pattern oriented, very repetitive. I can predict it down to the very words it's going to say. Um, and we should anticipate this pathology being here. So, 90%, the research suggests that 90% of parents are able to effectively resolve their custody issues without the court's involvement. So they either decide on their own what the custody schedule is, or they need that first orientation from the court to decide right after the divorce what the custody is, and then they're able to work with that, whatever the court decides. 10% of the population winds up coming back into the courts having to do with this attachment pathology in the child. And so there's also 10% of the population, roughly, is narcissistic or borderline or dark spectrum personalities. And it's those personalities that are coming into the family courts. So we should anticipate that and plan for it. When a when a court case around child custody post divorce re-enters the court after the custody has been decided with attachment pathology in the child, it should immediately get bumped out for a diagnostic risk assessment for possible child abuse. Either the targeted parent who's being rejected by the child is abusively, maltreating the child, and that needs to stop, creating the two-person parent-child conflict, or it's a three-person triangle. It's a cross-generational coalition, and the dark personality is creating a shared persecutory delusion in the child for manipulative secondary gain to manipulate the court's decisions around child custody, basically nullifying the court's authority and overturning the court's authority and orders for custody because they've induced a pathology in the child. So, one way or the other, if there's attachment pathology like this severe, where a child's rejecting a parent, either it's the targeted parent who's abusing the child, or it's the allied parent who's abusing the child. This is a two-person attribution of causality. The parent is producing the child's attachment pathology. This is a three-person attribution of causality into a triangle. That it's a family systems triangle, and there's a power dynamic. One parent is using the child as a weapon of spousal abuse or a weapon to gain more power over the custody situation. So this is not unexpected. I've described the pathology in detail. When it comes back into the courts the second time around, it needs to get bumped out to mental health for a proper diagnostic risk assessment. The problem is right now you won't find any mental health people who can do that because they are ignorant, incompetent, unethical, lazy child abusers. They're participating and colluding with the child abuse because of their incompetence and laziness and everything else. And they don't care. It's a motivational pathology. They don't care. So you're not going to be able to find a diagnostic risk assessment out there, and the court's not going to be able to find it. So I'm pointing that out. That's my role here. I'm a clinical psychologist, court-involved clinical psychologist. I am competent. I'm competent in attachment from my vita. I'm competent in personality, in thought disorders from my vita. I'm competent in family systems therapy. I'm competent in child abuse and child maltreatment. And I'm competent in this court-involved pathology. I've been over here for 10 years. So I am competent in all these domains of pathology, particularly attachment. This is an attachment pathology. My goodness. I have 0 to 5 background. I have treated attachment pathology in foster care. I have done a modified strange situation in a clinical practice. We had a one-way mirror at our clinic, and to instruct the students or the trainees coming through, and occasionally I wanted an attachment category for the child. And so we did a strange situation, put the child and the parent in a room, put a stranger in there, remove the parent, watch the child, then put the parent back in, and watch the reunion of the child and the parent. That's the key part. How do they reunite after the attachment breach, to see if they're anxious ambivalent, anxious avoidant, or disorganized attachment. But for the most part, you don't need to do a strange situation. That's for younger kids and stuff. And you never see an attachment pathology in an older child. You never see it. Okay, you don't see attachment pathology in an 11 or 12-year-old. You know why? Because you see it in early childhood, but if they have an okay attachment at 5 and 6 and 7, it doesn't go backwards at 8 or 9 or 10. That's not how the attachment system works. And so this is a false attachment pathology. You never see it out there. You'll see oppositional defiant behavior, but there this child is still trying to bond to the problem parent. They have an insecure attachment. You never see a child rejecting a parent. That just doesn't exist because that's not how the attachment system works. Any child who rejects a parent gets eaten by predators. It's as simple as that. So all the brain circuits that motivate a child to reject a problem parent are gone. They've been removed by the evolutionary history from the selective predation of children. When a child has a bad parent, they are more strongly motivated to bond to the bad parent because that's a way they might get protection from the predator. And so bad parenting produces an insecure attachment. These people in the family courts, these psychologists, have zero understanding of the attachment system. It's stunning. It's just stunning. And no one cares. They don't care. No one cares. So I'm over here pointing out their deficits, violations of standard 2.04, 2.01, 9.01. There's subsequent ones down 3.0, avoiding harm, the 2.03, maintaining competence. What's going to happen here, I anticipate, is as this awareness seeps into the courts and into the parents and into the mental health people and into everybody, that they are not competent to be doing any of this, the system's going to collapse. You won't have a psychologist over here. You'll have nobody who's able to assess, diagnose, or treat the pathology. That's currently the situation, but that will be exposed. Everybody will just have to acknowledge that, oh, we don't have any therapists or any psychologists over here who are competent because all the forensic psychologists are ignorant and unethical and incompetent. So we gave you your own special psychologists, and they are incompetent. They're awful. So that's going to be their problem, and they're going to have to try to fix it somehow. The likely way, what I'm thought, because I am competent, I gave them some assistance at this point. When they realize the depth of the issues involved in terms of their unethical malpractice, they're going to have to get up to speed really fast. And the current crop of forensic psychologists, they all need to go because they are unethical. They are just the worst possible psychologists. So we don't want to try to train up awful psychologists. We're going to actually go out to the real psychologists. I think that's the solution, to go out to the real psychologists, the clinical ones, and get them back. But then they're going to refuse to come, and that's going to, and rightly so, their license is at risk. So that's going to take some upper level kind of considerations within the profession about how do we supply the court with competent clinical psychologists. Some of them are going to have to come back, but they're not going to be competent with this court-involved pathology because they've been away from this for 40 years. So they're not going to understand the dark, narcissistic, borderline, shared persecutory delusion because they haven't seen it for 40 years. Once they get here, though, they will have the knowledge about narcissistic dark personalities, borderline pathology, shared delusional disorders, factitious disorder, attachment system, that they will be able to get up to speed relatively quickly. It's the court aspect, testimony in court, writing reports for the court, and a little bit on the treatment, getting the treatment standardized relative to the court that need to get up to speed with. So what I did was provide a couple of instruments to help scaffold the professional knowledge until it becomes competent. That's the diagnostic checklist for pathogenic parenting. That 3 symptoms will identify the pathology in the child. Any one will. If each one of those is diagnostic because the expected prevalence in the children is 0, no child rejects a normal range parent. That's not how the attachment system works. The prevalence of that is 0. A child rejecting a normal range parent. So that's diagnostic indicator 1. So I can make that the diagnosis of this pathology just on that symptom alone. It's a factitious attachment pathology imposed on the child. Diagnostic indicator 2 is Bowlby's volume 2. It's the protest behavior, either high angry, excessive angry, or excessive anxiety. And trauma as a pathology introduces the word extreme into any description. Extreme sadness, suicidality, you're in trauma. Extreme anxiety, panic, you're in trauma. Extreme anger, rages, you're in trauma. So extremes on any pathology indicates you're in a trauma pathology. And here you have an extreme rejection of a parent. The child wants nothing to do with that parent. And you have extremes of angry. There's very high angry, or extremes of fear. The child's, oh, I'm terrified of being with the other parent. We have a trauma pathology here. And the way I've operationally defined angry, extreme angry, and extreme fear, volume 2 of Bowlby's protest, is extreme anger is 5 narcissistic personality symptoms. And the reason I chose 5 is because that's the number the DSM uses for personality disorder, 5 symptoms of the personality traits. And that's not possible in a child. A child does not develop a narcissistic personality disorder. In childhood, the pathology that later develops into a narcissistic personality, in childhood, that's an insecure attachment. It would probably be an insecure avoidant attachment for a narcissist, insecure ambivalent for borderline. But you're going to see attachment pathology in childhood. Then at about 18 to 20, the personality coalesces, and whatever traumas were in the attachment networks, complex traumas, will then get sort of crystallized into the personality disorder pathology. So it's basically impossible for a child to have 5 narcissistic personality traits. They might have 1 or 2 kind of, but not 5. And the way I operationalized the anxiety was the DSM criteria for a specific phobia. But in this case, it would be a mother phobia or a father phobia. There's no such thing as a mother phobia or father phobia. It just doesn't not exist because the attachment system motivates bonding. It doesn't develop a phobia. And so both of those are false pathologies, a personality disorder in a child or a specific phobia about a parent in a child. So that's diagnostic. And the third symptom, diagnostic indicator, is a persecutory delusion in a child and towards a normal range parent, because that makes it a delusion. The parent is not abusing the child, is not maltreating the child, but the child believes they're being treated malevolently in some way by the normal range parenting of the parent. And so is there a persecutory delusion? The only possible source for a persecutory delusion in a child toward a parent is the psychological control and influence of the other parent. You have a shared persecutory delusion. If you see the persecutory delusion in the child, next session, call in the allied parent and check it out, and I bet you'll see the same persecutory belief system relative to the other parent as well. That the child needs to be protected from the malevolent treatment of the other parent. Shared persecutory delusion for secondary gain of manipulating the court. Um, and so those are just symptoms to help until the mental health people become competent. Because again, I can diagnose on any one of those symptoms. I gave you three of them because I figured the mental health people would be pretty insecure because they don't know what they're doing. So if they just have to use one symptom, that's kind of, but by giving them three, it's pretty solid. If you see all three of those, it's present. And then that makes a nice dichotomy too. If those three are present, then we have the pathology. If those aren't present, then it's subthreshold or it's something else. So that we'll deal with something else. But let's just deal with this severe case right now. Let's get a handle on this, and we can deal with the subthreshold or oddities down the road. The other thing I gave you was 12 associated clinical signs, and there's reasons for each one of those. Now, these are not diagnostic because they don't always show up, but they often show up. And so now, if you have the three diagnostic indicators and four or six of those ACS, the associated clinical signs, you're spot on with this pathology. That's a safe diagnosis at that point. And so that's what I gave to the incompetent mental health people over here to scaffold them during this period while they're learning Bowlby and learning about attachment and learning thought disorders and learning the mental status exam of thought and perception and learning about dark personalities and narcissistic and borderline personalities and complex trauma and child abuse. And oh, did I discuss Kohut and narcissism? Yeah, so there's a lot of stuff that they should know that they don't. And it's going to take them some time to get caught up. But, if you got back, let's say we brought in the dialectic behavior therapists, DBT, that's what I recommend. Marshall Linehan, very empirically solid treatment. It's for borderline personalities. We need to adapt it a little bit for the courts, but the therapist and the model is strong enough to deal with the pathology of narcissistic borderline dark personalities. And you need to be strong with that. My attachment people that I work with in attachment, they're too soft and gentle. If they wouldn't have the strength to be able to manage the disorganized attachment and cruelty and just pathology of a adult personality disorder or personality disorder spectrum. And so, but those are the good ones, the attachment people. So that's where I mentioned Sue Johnson and emotionally focused therapy. That ultimately that knowledge needs to inform the structure of the therapy. But it's the DBT therapist we want over here for the structure. But that'll give us some nice behavioral psychology from the 1940s and 50s. At least they know behaviorism. I'm not a fan of behaviorism, but at least they know it. So we can do an applied behavioral analysis. They will know what that is. We can do a stimulus chain or a behavior chain interview. They'll know what that is. They'll know what stimulus control and cues for the behavior are. And then they have that mindfulness, which is be wonderful for the trauma component. So we'll bring the DBT therapist back, but the DBT therapists are behavioral oriented. They're not going to know persecutory delusions. They're not going to know attachment pathology. They're not going to know child abuse and complex trauma or factitious disorder or the family courts. So they're going to have a number of domains where they're going to need to scaffold their competence. And that's what the diagnostic instruments do. Then the other thing I gave you was the parenting practices rating scale. Because everybody's saying the That's their first rule out. Everybody's saying the targeted parent is somehow maltreating the child, and that's causing the child's rejection, a two-person attribution of causality. This parent is somehow abusing the child. Okay, well, let's document that. Let's get clarity on that, because this is a pathology of lies, and the alternative is it's a delusion. So is that true or false? Somebody saying this parent is abusing the child. Is that true or false? If it's true, then we need to do something about it. If it's false, then we're looking at a possible persecutory delusion. So let's get clear on it. So I developed the parenting practices rating scale, breaks it down, parenting the targeted parent into 4 levels. Level 1 is clearly abusive. Level 2 is severely problematic. Those will be the abusive range parent. Level 3 is normal range problematic. No one's perfect, but it's normal range. And level 4 is normal range healthy. Those are your normal range parents. Um, and so, and then I even broke it down into what type. Are they over intrusive? Are they over angry? Or what's the problem with this parent, if there's a problem? And that way we can identify the problem, put it on a treatment plan, fix it, and everything will be fixed. Identify the problem, diagnose the problematic parenting, put it on a treatment plan, and fix it. Then we'll rebond the child to that problematic parent. If they are not problematic, if they're a level 3 or 4 normal range parent, then they are not causing it's not a two-person attribution of causality. They're not causing the severe attachment pathology. Then we look to a 3-person triangle as part of a family system. So that's a shared persecutory delusion. So, diagnostic checklist. Check, check, check. Are those present or absent? 1 is a child rejecting a normal range parent. I used fancy words and gave it a nice precise definition because it's a good research instrument. When research gets over here, that's going to be your operational definition for the pathology. 3 diagnostic criteria here, so that I defined them according to very precisely, let's put it that way. And so, is a child rejecting a parent? Is the child excessively angry or excessively anxious? Those are operationally defined. And does the child have a persecutory delusion? If those 3 symptoms are present, then we have the child psychological abuse diagnosis. What parents producing pathology in the child for secondary gain here. And is that a normal range parent, though? That's the second question. Or is the problem being caused by? Well, let's document it using the parenting practices rating scale. Then, how do we measure treatment gains? How do we measure, what's the outcome measure we use? And we should always have an outcome measure on treatment. So I developed the parenting practices rating scale, simple Likert scale on 3 items: affection, cooperation, social involvement. Little 7-point Likert scale. 1, 2 is awful, 6 and 7 is wonderful, nice normal curve. On this, 3, 4, 5 is what's normal. We want every day the targeted parent, child's with targeted parent rates the child every day on those 3 items and emails those scores to the therapist, puts them in an Excel file, and you can begin to track them. And then at the weekly therapy session, they can talk about any ratings of 2 or how did things go, and they can use that scale to sort of organize how they approach their discussion of family conflicts. And so those are instruments to be helpful. Now the pathology is trying to, it lies a lot, all the time. So it's saying that Dr. Childress has some sort of new theory and that it's going to try to, no, I don't. It's the established knowledge, it's the application of knowledge. And this is coming up with these instruments is what psychologists do all the time. Outcome measure. You go into the doctor, say, this hurts. The doctor says, on a scale of 1 to 10, how bad is your pain? It's called a SUD, subjective units of distress. So this is on a 1 to 7 scale, how affectionate is your child? Same thing. It's just a way of gathering the data. And so all mental health professionals should be routinely collecting the diagnostic checklist and the parenting practices rating scale. This is coming from Dr. Childress, who is competent in attachment, family systems therapy, personality pathology, complex trauma, child abuse, this court-involved pathology, factitious disorder imposed on another. By my vita, I am competent in all of those, and I'm telling you, you should be collecting routinely the diagnostic checklist for pathogenic parenting and the parenting practices rating scale, simply to document, to start with, what the child's symptoms are. Just document the symptoms. Then, if those symptoms are present, if we have a normal range parent and those symptoms, you have to explain them somehow. How do you explain these child's symptoms with a normal range parent? You got a shared delusion is symptom number 3. So, but the mental health people, if you go out and ask your mental health people, the parents out there, you say, would you please complete this for me? They will say no. They'll just say, no, I'm not going to tell you what your symptoms are, because that's how low the standard of practice is over here. Can you imagine you go into your doctor, you take your child into the doctor, and because you're worried about something, a physical problem, a medical problem, you take your child into the doctor and you say, doctor, what are my child's symptoms? The doctor says, I'm not going to tell you. What do you mean you're not going to tell me? What's my diagnosis? I don't diagnose pathology. What? I brought my child in for a medical concern, and you're not going to tell me what the symptoms are? You're not going to tell me what the diagnosis is? You're just going to do some sort of treatment? Is there any wonder nothing's been solved in 40 years? Is there any wonder? No, this is the worst. It is so low. The Gardnerian PAS people, Bill Burnett and Amy Baker and Jennifer Harmon, that whole crew, Gottlieb, they are degrading the professional standards of practice by using this parental alienation term. And that needs to stop. They need to be talking about shared delusional disorders or factitious disorders or child psychological abuse. It's all very interesting that they have this new parental alienation thing, but it's failed for 40 years because it's awful, absolutely awful as a diagnostic model. And the APA, American Psychiatric Association, was absolutely correct in rejecting it. But they don't take no for an answer. They're fixed in false belief, maintained despite contrary evidence. They believe that this is somehow effective or somehow a thing to do. But no, it's not. It's degrading the quality of professional practice over here. We need to get actual diagnoses. We need to get actual treatments, not something they just make up. And so they're a problem. But my guess is they will just be kind of moved aside into the annals of history, just placed on a bookshelf over there as an interesting oddity of a period of time. Forensic psychology needs to end. It is a failed model of service delivery to a vulnerable population. We've tried your own special psychologists for 40 years. It has failed miserably. And so we need to reintegrate these families into the family courts back into clinical psychology, as dangerous as they are to your license. And the people who are going to be working with them, hopefully all of us, will just need to be more structured in our approach. So if the clinical psychologists come back, do the diagnostic checklist, parenting practices rating scale, and then have an outcome measure of the parent-child relationship rating scale, they'll be okay. They'll be safe because they're relying on my competence and my diagnostic expertise. If they're using my instruments and doing what I'm saying, then they are relying on my knowledge, and they will be safe and supported in what they do. So, but let me sort of wrap up here a little bit on the child therapists, because I'll be talking more about therapy on Sunday. But the child therapists are the absolute worst mental health professional here. They are most specifically the ones who are participating in the psychological abuse of the child. And because they are not conducting a proper assessment of the pathology, they are misdiagnosing the shared delusion as being true. So the child comes to them and complains about the targeted parent, and they say, "Oh, you poor child, oh," and they give support to the child as if that was true. They are communicating to the child that the delusion is accurate. So the child is getting delusional information from a parent and healthy, normal information from the other parent, but the child doesn't know which one to believe of these two parents because one's nullifying the other, and who do I believe? So the third person of the therapist is critical in this. It is up to the third person of the therapist to see the shared delusion and to give the child a normal range interpretation of the divorce and the parenting. No, your mom is not abusing you. That's not abusive maltreatment. That's normal range parenting. No, your dad's not to blame for the divorce. That you need to stay out. The therapist needs to be giving the child a normal range interpretation of the situation. The individual therapists do not do that. The child comes in, complains about the targeted parent, and they give the child support as if that was true. They are creating the shared persecutory delusion. They are part of the shared persecutory delusion. They are part of the child abuse. So, there is no reason for an individual therapist with this court involved pathology. The child does not have a pathology that needs treatment. The child's family has a pathology that needs treatment, but the child does not have a pathology that needs treatment. And so there's no need for an individual therapist. And when I come on with any case where there's an individual therapist, I'm going to want to know what the diagnosis is and what the treatment plan is. What are you treating? Anxiety, depression, and how? And did you properly diagnose for a shared persecutory delusion? No, they didn't. And they have this belief that they do this safe harbor therapy. No way. The allied parent pumps that child for information. They know what's going on in that session. The child is being psychologically controlled. There's no safe harbor for a child who's being psychologically abused. That's nonsense. And so we need to come in and recognize what the pathology is with a dark Machiavellian manipulation of a dark personality and not believe the child and all. We need to apply knowledge and protect the child. If the targeted parent is abusing the child or maltreating the child, let's diagnose it, absolutely. But if they're not, then we have spousal abuse using the child as a weapon. We got psychological abuse of the child. So when there is a possible child abuse diagnosis involved, our diagnosis has to be accurate 100% of the time. Okay, because the consequences for misdiagnosing child abuse are too severe for the child. And so these individual therapists that are out there are substantially misdiagnosing the pathology because they are failing to take proper care in their assessments, and they're practicing beyond the boundaries of their competence with attachment pathology and delusional pathology. They should be consulting, they should be getting knowledge, they should be doing stuff. If they come to me, get my information, that will be more than helpful for them, but they're not motivated. And so they just keep doing the same thing. And they are the individual therapists are the child abusers. So as I come in, I'm focused on the custody evaluators right now and reorienting that practice because it's an abomination. It's simply exploitation. 6 to 9 months for an assessment for $20,000 to $40,000. That's obscene. I can bring back a clinical diagnostic assessment in 4 to 6 weeks for $2,500. That should be the goal. For every family, a diagnostic assessment, 4 to 6 weeks, $2,500. Second opinion up around $5,000. So $5,000 for a second opinion on a court-involved matter. Yeah, that's absolutely doable. Not $20,000 to $40,000, 6 to 9 months. But it gives no diagnosis, and you still need a clinical diagnosis even after the forensic evaluation. It solves absolutely nothing. In clinical psychology, I was clinical director and served as a supervisor on the number of the postdocs and trainees, and we had Department of Mental Health had all sorts of requirements for charting and things. If you, and this is the way I was trained at Children's Hospital, if your report is after 6 weeks, it's no longer responsive to the referral question. We need another assessment again. If you're out at 8 weeks or 12 weeks on your report, 3 months on your report, no, that's out of date. We need a current assessment to make current decisions about the child. So the standard in clinical psychology I work with for all my interns and trainees is you want a turnaround on your report from the assessment to your report of 4 to 6 weeks. After that, it's non-responsive to the referral question. 6 to 9 months for a forensic evaluation? If that child is being psychologically abused, and they are, that's 6 to 9 months that you've allowed that child to be with an abusive parent. That's negligence. That's absolute negligence. If there's a possible child abuse diagnosis, which there is anytime a child's rejecting a parent, that forensic psychologist has an obligation to turn that around really fast to get information to the court about protecting the child. But it is just a nightmare over here. So I'm focused up on the forensic people at this point. But I have my eye down to the individual therapist. So just a word to the wise out there on parents. You don't need an individual therapist on this, and you need a family therapist. Look for the dialectic behavior therapist and see if you can get them to come back into the court-involved stuff. They'll likely refuse because it's too dangerous. They'll say, I don't know, I don't deal with court-involved stuff. I don't know what to tell you about the forensic people. They're just ignorant like a rock. And there will be a period of time here where everything's kind of problematic regarding mental health services that are available to you. I'm here for consultation to any mental health professional, and telehealth consultation. Look at this wonderful new internet kind of thing. Let's use it. We should always be going in with second opinions on our diagnosis into the court because it's going to be disputed. The appellate system in healthcare for a disputed diagnosis is second opinion. So rather than get a diagnosis, then dispute it, and then get a second diagnosis, and then dispute that, and then everybody's fine. Let's get them right up front. Let's get the second diagnosis and the second opinion right up front and take that confirmed diagnosis with the second opinion to the court. The court can then be reassured that it's acting on an accurate diagnosis and then move into a proper response. And if it's child abuse, the proper response is to protect the child. If it's not child abuse, then parents have the right to parent according to their cultural values, personal values, and religious values. And to separate a child from a parent, if there's no child abuse, to separate a child from parent is creating attachment pathology. It would damage the child's attachment bond to that parent, harming the parent and harming the child. So if there's no child abuse, we don't separate children from parents. That's creating attachment pathology. But in this case, there's likely child abuse because one way or the other, that's the only thing that causes this attachment pathology. Well, with that, I'm going to sign off and get back to my world, and I'll see you on Sunday morning for coffee. We'll talk about treatment of children.